Good afternoon, everyone, and welcome to our Dissemination Research and Implementation Science Seminar, or DRISS. My name is Heidi Brown, and I am the moderator for today's session. I am one of the faculty members on the Launchpad. I'm an associate professor in the Department of OBGYN, and my work focuses on dissemination and implementation of interventions to improve incontinence in older women. So this seminar, DRISS, is our interactive monthly lunchtime virtual seminar to learn about the growing science of dissemination and implementation. We appreciate you being here today and hope you continue to join us for future sessions. You can join the DRISS mailing list by clicking the link in the chat, which we'll put in a couple minutes. And you can also see what the upcoming sessions are by looking on our DRISS website. Today, we have the great honor of hearing from Dr. Jane Mahoney, and her talk is titled Integration of D&I within Translational Science, Examples from UW-Madison ICTR. Dr. Mahoney is a faculty member in the Division of Geriatrics and Gerontology in our Department of Medicine, and is an affiliate faculty member of the UW-Madison Institute on Aging, as well as the director of CAARN, the Community Academic Aging Research Network, and the director of the D&I Launchpad and the associate director for implementation science at ICTR, as well as ICTR director of D&I resources and the associate director for D&I science at UW's PRC, or Prevention Research Center. So Dr. Mahoney has been my research mentor since I joined UW. I met her at the D&I short course in 2013. Dr. Mahoney has developed highly successful programs in falls prevention and is nationally recognized for her pioneering research in falls and novel interventions to reduce falls in community dwelling older adults, as well as dissemination and implementation research on the Stepping on Falls Prevention Program, which is now in use throughout Wisconsin and many states. She has conducted research on contextual factors and strategies that promote adoption of evidence-based interventions in community settings. Dr. Mahoney's research has been supported by peer-reviewed grants from the CDC, NIH, and AHRQ. Her presentation today will provide a framework for considering how dissemination and implementation sciences can help advance our translational research efficiency and effectiveness across all translational stages, T1 through T4. It also provides examples of how ICTR has integrated D&I sciences into training, funding, tools, and support that ICTR provides to translational researchers. Jane will present for about 30 to 40 minutes, and then we'll have about 20 minutes for discussion and comments, and we'll encourage you to be part of this. We changed our format today from our prior format to a formal webinar. So that means that when you want to make a comment, you raise your hand, and then we will allow you to make the comment, as opposed to just being able to unmute on your own, which is a change from our prior DRISS seminars for our repeat community members. So with that, I'm going to turn it over to Jane to teach us all about the amazing work that she and the Launchpad have been doing. Thanks so much for being here, Jane.
Thank you, Heidi. Looking forward to talking today. So I'm just going to pull up my screen now and then get myself into the slide mode. So hang on just a minute. I think this. Oh no. So now you can see my screen, but it is not in, let me get it in presentation mode. Now, can you see presentation mode on your, yeah?
It's perfect, Jane, you got it.
Okay, great. So I'll go ahead and get started. And I always start with definitions because it keeps us all on the same page. Dissemination, I think we all know, is the distribution of information and intervention materials to specific audiences to spread knowledge regarding evidence. in the audiences that we think of with dissemination are public health and clinical, those who could use the information. Implementation is the use of the information that's been disseminated. So it's the use of strategies to adopt and integrate that information or evidence-based health interventions into practice within specific settings, whether clinical or community. So I'm going to talk a little about the sciences that underpin that dissemination implementation sciences that underpin translational research and how they relate to each other. And this is work that our D&I National Working Group, which is sponsored by the CTSA Consortium, did. Our first one was looking at D&I sciences within and across the translational research spectrum. So if we look at a few more definitions, translational science is the science of how we do translational research, what is needed to take observations into interventions that improve health. So translational science seeks to understand those underlying scientific and operational principles that arc from what we call T1 to T4, cells to bench to bedside. So dissemination implementation science is similar goals or analogous. What is needed to effectively and efficiently disseminate and implement interventions? What we were trying to conceptualize in our D&I National Working Group and trying to understand is in what way, if at all, D&I sciences can apply across all stages of the translational research spectrum. And we conceptualize that there are sort of four underlying principles that are integral to D&I sciences that we have seen in late stage translational research, which is where we're really looking at the clinical translation and translation into community, but could also apply to earlier stages. So the first is that context matters and is multi-level. So we really have to understand the context in which we're trying to move interventions or move research into practice. Second, it's not sufficient that evidence exists and/or practice works. It actually takes nudges and pushes to get evidence into practice, and it takes supports frequently to help adopt and take up evidence and put it into practice. So that goes along with the change happens proactively. And then the fourth one is that implementation practice, which is the support we provide for implementation, and implementation science are team endeavors, very multidisciplinary, but it involves clinical scientists to social scientists to systems engineers to communication scientists and practitioners. So our key question that we were trying to ask was, do these questions apply, these principles apply to translational research at its earlier stages? So the model that we conceptualized was this integrated framework of dissemination, implementation, and translation, which is called IFDIT. And this, the wheel with the 5 pies is actually on NCAT's, the CTSA National Sites webpage, representing the translational research spectrum, often seen as beginning at basic research, into preclinical research, where we're doing human safety and efficacy trials, to clinical research, where we're doing clinical pragmatic and hybrid effectiveness implementation trials, clinical implementation, and public health. But conceptualizing that it's not necessarily you go around the circle, it's often very integrative and can move, can potentially jump backwards and forwards from a circular approach. we conceptualize that D&I sciences apply both within a stage of research, translational research stage, and across, moving from one stage to another. Within, we defined as applying to research conduct, and across, applying to application. How do we apply research from one stage towards another stage? And that D&I sciences matter to both. So the key propositions are that there's the research conduct within and application between. And while the stakeholders, contexts, and types of research vary from one stage to another, the underlying processes are fundamentally the same. And these principles, the 4 principles that we talked about, and I'll go through later, have application and can help guide these research conduct and application to make it more efficient and productive. So what we've learned from optimizing research in the later stages of translational research, clinical and public health, can apply to earlier stages and help as well at those stages. So earlier stage research conduct is really aiming to generate new knowledge, for example, about whether a biomarker is found in patients with certain conditions at different rates from the population. And late stage aims to generate new knowledge about what specific strategy is effective, for example, in increasing adoption and use of a research tested intervention. Both have to do with generating new knowledge. Research application has to do with engaging, how we engage stakeholders in taking up the results. At early stage, who are the stakeholders? It may be the next stage of translational researchers, the scientific community, could be funders, other stakeholders. How can they take up the results from earlier studies and move them towards later studies? Late stage research application aims to engage real world users, policymakers, other stakeholders in taking up interventions that we found effective in clinical effectiveness studies. So both are about engaging and moving research to another stage, ultimately into practice. So if we think about how D&I principles can apply in late and early stage translational research, this is from the publication, this one of the tables from the publication, but these principles have implications for both late stage research, which is sort of where D&I has been seen as its primary home, but also have a rationale for their role in early stage research. And I won't go through all of these in great detail, but let's just take the first one. Context matters and is multi-level. The implication for late stage research is that if we want to successfully disseminate research knowledge and get it implemented in practice, it's very affected by contexts such as healthcare policy, organizational community culture, and climate, attitudes and behaviors of key stakeholders. And so understanding that context affects how good a job we can do at getting things taken up into practice. For early stage research, all research is conducted and translated or moved from stage to stage within a complex multi-level context, which relates to funders, the research environment, the ability to quickly move things through what is available and what resources are available. So again, a multi-level context. For each one of these principles, you can go through and identify the rationale for their role in early stage research. So for example, with it's not sufficient that evidence exists and or practice works. The rationale for role in early stage research is that intervention design and development benefits from understanding the factors that influence later stage adoption and implementation. such as usability, desirability, feasibility, and cost. And drug manufacturers know this as they think early, even at early stages. Usability means, can we make a once a day formulation instead of a 4 times a day formulation? So understanding early on those factors can be very important, even at preclinical stages. Change happens proactively. Even in early stages of research, people working in systems decide what research will be pursued, how it will be moved forward, how it will be done. So strategies that can be used by leaders and systems influence the way that we can both do research within a stage and move it forward to the next stage. And then their team endeavors. So the rationale for the use of that principle in early stage research would be that if we can have bidirectional exchange of information and perspectives between stages, like move things from bench to clinical research and create bidirectional communication systems, we can more likely bridge translational gaps, even in early stages. So when we think about using D&I sciences to benefit research conduct within a translational research stage, what we try to conceptualize is what could be the use even at a basic and preclinical or a clinical research stage. And if we think about basic research and look in the column, potential use of dissemination science, can we understand the social pressures among basic scientists that inform the research questions they pursue? And then use that to help shape the types of questions that we do pursue. Implementation science could be used to study the effective strategies to improve efficient best practice laboratory procedures among staff. Preclinical research, marketing principles could inform participant recruitment strategies to bring to trials, even in the early and thinking towards preclinical stages. And you could use economic strategies to improve participant engagement and retention in very early stage safety efficacy trials. Clinical research at this stage where you're really starting to move things into clinical research, D&I sciences again play a role in helping us optimize communication among study teams and improve adherence to study protocols. So what if we think about between stages, trying to more quickly and efficiently move research from the basic science stage to the preclinical, for example? How can we use dissemination science? So we could compare strategies for disseminating evidence from basic research to receptive preclinical research centers. What strategies do we have and pursue to disseminate? How well do they work? When we think about implementation science in designing preclinical research intervention for a trial, we could consider barriers to adoption of similar interventions and modify and begin to do those even at in the early design phase as you're moving from basic research to preclinical. The same for preclinical to clinical. If you think about dissemination science, you could compare strategies for disseminating evidence from preclinical to clinical research centers, funders. Again, with that idea of how do we reduce silos to more quickly move research from one phase to another so it can be used at the next phase. Implementation sciences, can we think about design methods to consider barriers to adoption, particularly, for example, with historically underrepresented communities, barriers to recruitment and adoption? So I'm going to give you a case example from UW, from here, which we should be proud of because it has to do with cheese. And this is related to looking at GMP for phenylketonuria. So phenylketonuria is an inborn error of metabolism where, oops, my apologies. There is a need to have a very strict diet to prevent buildup of ketones, which is the cause of phenylketonuria in those who cannot digest certain proteins. So basic science research at UW-Madison isolated GMP from cheese making as part of the whey, W-H-E-Y. And first researchers reached out to PKU Alliance, which was based out of the Weissman Center in Madison, to learn about the context. Could this be important, this GMP, for preventing the damage that occurs from phenylketonuria? And that led to establishing a multi-stakeholder GMP for PKU task force. And this happened very early on, before WRF even patented it, and before they did any clinical trials. Very early on, also, patients were engaged to provide feedback on what is palatable and desirable. And this led to more clinical testing, and eventually a small foods company, which now licenses the product and has developed a marketing strategy, which is they're using worldwide. So this is sort of using that idea of understanding the context was something that happened very early on. Understanding how to reach out to stakeholders, and proactively working with stakeholders, proactively beginning to identify how to make it palatable and desirable as a food source, and then bringing in team science very early on, including the end user stakeholders. So in summary, this IFTIT model, we feel, applies both within the translational spectrum in each stage, T1 to T4, and then across the translational spectrum, and helping to more quickly move things from the basic observation of GMP in as a byproduct of whey to having a food source that could be marketed nationally. So our second question that we asked is if, as part of our national working group, is D&I Sciences help advance translational research efficiency and effectiveness? How can we best support their use within CTSAs? And for this, we conceptualized that CTSAs concern themselves with methods and processes to support translational research, workforce development to create a workforce of translational researchers, and then evaluation, how well are we doing at moving things, advancing translational science and the translational research enterprise, ultimately to create impact. So within that context, you can see on the right side the translational research spectrum again, with D&I principles being potentially embedded across in all stages of research. D&I scientific principles also apply to the practice. So what happens when we're actually trying to translate research into practice, leading to outcomes, D&I outcomes, translational outcomes, scientific output, and ultimately health and social impacts. So CTSA hubs support both the research and the practice arms ultimately, and the workforce development and methods and processes and evaluation ultimately to do the best job of moving research to practice should concern itself with both arms. So, for example, as implications for workforce development, these fundamental principles of D&I apply across workforces, both in the research and the practice arms. So we tried to think about what are example competencies that would be relevant across workforces. So, for example, the principle that context matters and is multi-level. A competency for the workforce, whether it's translational researchers from T1 to T4, or whether it is practitioners, is to understand the questions that are of high relevance to stakeholders and just be able to describe factors that influence research, adoption, implementation, maintenance, and reach. So for each of the principles, we developed some example competencies. This work isn't done, but example competencies that would be relevant across the translational and practitioner workforce. Now, the degree of competency varies both by translational stage. So you would anticipate that T3, T4 practitioners would require higher competency and understanding of how to apply D&I principles and D&I science. By type of workforce as well, translational researchers may have less, but D&I consultants and researchers may have need for higher or more intense degree of competency, and then by learner stage as well. So when we think about CTSAs, they really, including ICTR, provide an ideal structure to build supports for translational research and translation into practice. And as we think about building capacity and what our CTSA has done as in sort of many ways exemplifying this, what can be done. We think about what can we do for training, providing tools and methods, funding, and then expertise. So I'm going to just explain a little about what we have been doing here that to build supports for that enterprise. So we have provided training, research funding, and supporting tools for translational researchers. And some of the supporting tools would include consultants, toolkits on how to develop a dissemination plan, nudges for RFAs that say you should engage stakeholders. Please tell us who your stakeholders are, and please tell us what your dissemination plan is. So both training, funding for that, and then nudges that help support doing the right thing. Workshops would be one aspect of where we can actually help researchers identify how to use these tools and principles within their research applications. And we also provide consultation, whether it's implementation science, marketing, business, all the areas that need to support the D&I, the translational research and practice enterprise. At the same time, and this is an area where I think there's room to build, but training practitioners includes training practice-based research networks and providing funding and supporting tools to support their ability to serve as train-the-trainers for practitioners in the field. For example, public health nurses and others who want to implement research into practice. In terms of thinking about translational research, the research part of the enterprise, not the practice arm. So we have done a number of things, and now we happily can add the DRISS seminar to that, a number of ways to train, particularly the T3 to T4 researcher workforce, but I'll talk about some of the earlier training. Implementation Science Monthly Discussion Group run with Maureen Smith, the D&I short course, the Implementation Science and Community Health Outcomes Graduate Certificate, Capstone Certificate. We have research funding for the D&I Research Pilot Award, design for dissemination tools and supports that really are helpful for T2 through T4. and training that, particularly with the KL2 scholars, that relates to, has pertinence to the earlier stages of translational research workforce. So one of our foci most recently has been on design for dissemination. This is a definition from 2013, but still holds that D4D is an active process that helps to ensure that health interventions, often evaluated by researchers, are developed in ways that match well with adopters' needs, assets, and timeframes. So the adopters are those who take up the interventions into practice. Adopters also relate in that if-DIT model to those who take up findings from earlier research stages and move them into a next stage of research. So that design for dissemination also includes designing for moving to a later research stage, and how can we help do that? Who are the stakeholders in thinking about design for dissemination or translation? Those who benefit from the intervention. And, you know, as I'm thinking about this now, I'm also thinking that as you think about this, you think about moving from T1 to T2 or T2 to T3. There are defined stakeholders that you can say who are the stakeholders in moving to the next stage of research. And so the stakeholders include those who would take up the next stage, those who benefit from the, if we take now going back to research that's ready for translation, benefit from the intervention, put it into practice, who would distribute the intervention with fidelity, payers that pay for it, and those who develop the intervention. So when you're thinking about T3 and T4 research, design for dissemination has to do with thinking about, as you're designing an intervention to be implemented into practice, whether community or clinical, understanding all these stakeholders, what's their stake in the game. So the idea is that even at the design phase, you are incorporating their input, understanding their barriers and facilitators and incentives, and creating a design that will make it easy to move into the dissemination phase. So the goal with integrating D4D into translational research is to, our goal has been to maximize likelihood that it's used by investigators, and ultimately that D4D plays a role in intervention design, testing, and refinement. We've created a number of supports and nudges. Our D&I short course in 2019, but every year we come back to this theme. But the short course in 2019 was on design for dissemination. We trained PBRN leads and staff to coach investigators. We integrated D4D, this idea of engaging adopters and as being an important part of your research proposal and being part of what you're reviewed on, and then provide easy links to consultation with the D&I Launchpad. We also built tools and resources, which most recently in all of these areas we strengthened by putting an equity focus so that we ensure that we design for equitable dissemination. I think I'm going to skip through these tools that are on our website. Now have been enhanced to make sure they include equity first. We did an evaluation of our first stage of when we first integrated D4D into the ICTR pilot research, RFAs and proposals. We did consultations with 2/3 of our applicants for the 2020 CAARN Pilot Award RFA, and then all applicants for the 2021 award. And we covered areas such as engaging adopters. How do you engage adopters? How do you develop a value proposition? how do you develop dissemination plans, and how do you develop study designs that test feasibility of adoption or look at feasibility of adoption. We received highly positive feedback with most people feeling that it strengthened their grant applications, particularly for the community reviews. And the result, when we looked and compared earlier applications compared to the 2020 and 2021 awards, was an increased integration of plans to engage adopters in research proposals. We've also worked with training KL2 scholars, and this is something Heidi and Felice have done a lot of. So the curriculum has included sort of a focus on design for dissemination across all 4 years, with principles of D&I science for first-year scholars, advanced D&I principles for second-year scholars, and then encouraging people to develop individualized stakeholder engagement plans and engage stakeholders, even beginning in their first year, and then broaden the stakeholder engagement as they move along. Within year 3 and 4, having opportunities for mentored application of D&I concepts to their research question. We worked with one scholar who was doing work on T1, the T1 research stage on fibrosis in BPH, benign prostatic hypertrophy. And her research was to identify mechanisms to interrupt fibrosis formation in BPH. We helped her set up meetings with identify stakeholders, in which in her case were family practitioners and geriatricians, and design questions to ask of the stakeholders. And Heidi was very involved in this. The rationale being most patients with BPH seek care from their primary providers. And the goal was to understand what are primary care provider perspectives on diagnosing and treating BPH. And would therapy to reduce fibrosis be seen as useful by primary care providers? So there turned out to be several important findings from this early stakeholder engagement, which helped her think about where her research would go from the T1 towards the T2 stage. So our goal over the next several years is to expand this work with case scholars and advance translational science by incorporating this type of stakeholder engagement, D&I principles, in early stage translational research and training. So more to come. So I think I'm going to stop here so that we can begin to answer questions and have further discussion. So thank you very much.
Thank you so much, Jane. And I appreciate you stopping sharing screen. At this time, I would like to encourage participants to indicate questions. We can unmute you so that you can speak directly to Dr. Mahoney. And I will start us off with the first question, Dr. Mahoney, which is, what advice would you give to the folks who believe that their work is too early to think about dissemination and implementation?
You know, I really would like, I sort of go like leading by example, teaching by example. And when you give that PKU example, I mean, they were really at the T1 stage, looking at isolates from whey, the byproduct of cheese making, and very quickly began to engage stakeholders to move it towards a T2, 3, 4, doing what we think of as more T3, T4 feasibility, acceptability work, and thinking about translation, even as they were setting up for their clinical effectiveness trials. So that was very exciting because it did result in a pretty quick impact. And so I think the IFDIT model gives sort of a theoretical framework to understand, and the principles give a theoretical framework to understand how you can move things quickly and how important it is. But I think we need to just accrue more examples. It is new, it is innovative, it's advancing translational science, but we've all heard that 17 years to get 14% of basic science research findings into practice. And so we know we have to do whatever we can to shorten it. So it's an exciting proposition. What if you begin to bring the stakeholders and users early on? And I think Petra found that helpful. So I think giving more examples is helpful to show investigators how you can move from the model. But I don't have any, do you have any other ideas? That's a good question. This is a D&I question.
What I always say is that even if it's effective, if it's not implementable, its effectiveness doesn't matter, because I think that we've been so indoctrinated that the RCT is the gold standard, that we think we need to prove effectiveness before we start thinking about implementation and dissemination. And the truth is that by incorporating those questions from the beginning, you actually may be able to compromise a little bit on effectiveness if your intervention has great reach. So I think by, this sort of, we've all thought that the RCT is the gold standard for so long, and that if you don't have effectiveness data, you can't move forward. But the truth is that it's an and rather than an if, like 1, 2. It's a, I think it co-occurs.
Yeah, and Heidi, one other thing I want to say about that is when feasibility trials are, feasibility pilots are well accepted as important. And part of it is enlarging our mindset that feasibility means not just feasibility of implementation and use by patients, but also feasibility of adoption. And so it's just a slight expansion to think we're identifying whether the leaders of a health system or a community organization at a top organizational level would say, oh yeah, this is worth doing, and building that into feasibility trials. At the same time, at the effectiveness stages, we now have hybrid study designs that allow us to look at both implementation outcomes and relevance, as well as effectiveness. So I think the science is moving us there more and more. So I see Casper's question on what are your insights about projects that have to loop back and revisit the stages of D&I for projects that are complete but did not plan well or design well? Yes, this is exactly getting at what you said, Heidi, and my own experience as well. Building a perfect mousetrap that's effective but cannot be used. And I've done that, which it makes, and you see, so I would say that translational research is littered with studies that have turned out to not be implementable, the findings, because they weren't planned well. So as you're even thinking about an effectiveness trial, thinking, it's really hard to separate effectiveness of a complex intervention from what it takes to implement it well, because you need to make it feasible to be implemented if it's going to be effective. And an easy example would be, sure, 4 times a day medication may be effective, but if people it's not implementable because people don't want to take 4 times a day medications and can't, then it's not, it could be efficacious, but it's not effective in practice. So again, that idea of design with implementation success in mind is so important. The other thing I'd say is we now have tools, particularly with design thinking, to not have to wait till we do a feasibility test to find out if something works or not. We can now proactively design and create a prototype that is highly likely to be feasible, adoptable, implementable, all that.
Thank you. There's also a question here from Peggy. And Peggy, I believe I made you a panelist, so I believe that means you can unmute yourself to ask your question. Or perhaps not.
Sorry, Heidi, it took me a second. Thanks. Jane, I just sort of speaking to what both you and Heidi mentioned, that we had a clinician scientist who tends to be on the fairly early end contact Rachel, Melanie and I about an E2I. And after talking to him, we found out, well, he's not even close to an E2I. But when I was talking to him about potential ways to fund his project, including a C-Corps, he hadn't even considered a patient advocacy group who, after talking to him, it's like, well, Matt, who are you going to work with later? And he's like, I said, is there a group or a patient group or a society or somebody you could work with? And he's like, oh yeah, there is. And I said, would you be using them to help you disseminate? Oh yeah, I would. And it's like, have you contacted them at all? No, I haven't. And so I think it's a fairly common thing for T1, T2 researchers. They're not thinking that far ahead. They don't see a role for them necessarily. And I applaud both Heidi and Felice for the work you've done with the KL2 scholars, because I feel like that has been very successful. And they love the discussions, and a lot of them are T1, T2. So they're in that boat where it's not obvious to them what the next step is or how they would include, how they would engage stakeholders and include them in their research and the design and stuff. So I'm extremely thrilled about what's been happening with the KL2 scholars in particular, because I think it's a definite need, as we could tell from people who aren't KL2 scholars that are asking some of those exact same questions.
Thank you, Peggy. That is really great. And yes, I think that, it's true at the early research stages and still even at the later translational research stages. And that's why somebody using a systematic sort of scientific approach, outlining who your stakeholders are, and at a later stage, it becomes more important to think about payers, but it could apply across all stages. So thinking about payers and advocates and adopters, until you sort of systematically raise the question, you don't begin to think about it. The thing I would say it's a little analogous to, which we're all learning, is the same as true for equity. If you don't systematically raise the question of who's not at the table, then we end up designing for the most privileged people in society who can have health literacy, easy access to resources, and more money to get resources. And so designing for equity is a similar thing of saying, when we make sure we're looking at stakeholders, that we're considering stakeholders from historically underrepresented communities. But I think it's just perhaps maybe having a checklist, a pause with a set of questions that, but you have to understand the value of it. And that's where these good examples and value propositions are so important.
We have about 5 minutes left for questions. So if someone has a question, if you let us know in the chat, we can unmute you. And I will ask another question. So I often say that hybrid trials where specifically type 1 hybrids, where you're focused mostly on effectiveness, but you're collecting some implementation data, are the gateway drug for people doing clinical research who are just starting to get into implementation science. And I think there's some advice about ways to dip your toe in for folks who are learning more about this work. Jane, I don't know if you have other suggested gateway drugs other than the hybrid trial.
That's so interesting. I think sort of what we try to provide in each short course is a set of gateway drugs, really, in a way. And you may start with one that really resonates and then go to another, depending on your need. So for some people, understanding CFR, where they can really, the consolidated framework for implementation research, where they can really understand what's the context, who do I need to engage to identify barriers and facilitators that make something work. Last year, well, the year before, we learned about EPIS framework, which it holds true, I would say, for clinical trials and any stage of research. Going systematically through the exploration phase, the preparation, implementation, and sustainment phases are really important. And as an example, I love to give this example of a colleague of mine at another university who wanted to look at do bed alarms work to prevent falls. Well, without doing a lot of the preparation at the exploration stage, even, or the preparation stage, he said, okay, we're just going to randomize to bed alarms or not bed alarms and look at fall rates. They did do a process evaluation and found out that nurses don't use, in these hospitals, did not use bed alarms because they're too complicated and annoying when the alarms go off. So it makes you realize that in any stage of a clinical trial, understanding the preparing to have it implemented well, the intervention or the clinical trial implemented well is so important. Another great example that I think we've all become heightened more aware of is you need to do the same thing to create realistic, feasible, recruitment plans that are going to be likely to be successful in recruitment, because inability to recruit is sort of the #1 downfall of the clinical trial. So that EPIS is a very helpful framework. Implementation outcomes is a helpful framework to help you understand. So what are important things to think about as you're preparing and planning?
Thank you. There are a number of questions in the chat now that are, I think, relevant, and perhaps Peggy will also be able to answer. So I guess the first one is from Mike. Mike, do you want to ask your question?
Sure. Can you hear me?
Yeah.
I was just wondering about the opportunity to start to integrate this into our grad programs. Like, so our PhD students are in the clinical and biomedical research areas. I just think this would be so valuable for them to begin getting, at that stage of their career. And I'm just wondering if you had suggestions on how to begin to integrate that, or if there are conversations or plans around that.
Maybe, yes, absolutely. And that would be sort of what that article was suggesting, is that beginning early and having people just beginning to dip their toes in it. And that could apply to clinical investigation for sure. It is part of the ISHO certificate. And but I do believe that we have more for clinical investigation, PhD, and some of the other PhDs, master's programs on campus. But that would be, Peggy, I don't know if you want to talk about that a little, or food for future thought and work.
Yeah, that's a great idea, Jane. I think the one thing is PHS 709 that Andy's teaching, that he took over from Maureen Smith, is a course that has more D&I in it, and it's just a single course. So that might be a good spot for a graduate student to add as an elective to their coursework. And as you mentioned, the ISHO certificate certainly is an opportunity, but that's a few more credits than taking the one course. But and then Heidi, as Heidi just put up in the chat, that this can be done for a seminar. So, I think it's definitely something, we have talked a lot about with our degree, the GIPSY, the clinical investigation degree and certificates, and trying to include that more, Jane, in and Mike in the curriculum, so that we don't leave this out, because it is such a critical area for students.
I
Thanks.
think, these monthly seminars are free. Anybody at UW can attend them. And if you have a grad student who wants to get credit, you can, if you attend 10 of these or watch the recorded ones that we have on the website, they can get a 1 credit seminar in dissemination research and implementation science. And then, there's little thought exercises so that and then, I'm the faculty person and I review and give little comments. Also, the D&I Launchpad has consults for people who want to, anybody at UW can request a consult to sort of bring their research idea to the Launchpad. And we do it's basically a tailored consult, 1 hour for you based on what your research questions are and how which frameworks might be most relevant at the stage of work that you're at, who you might want to engage, what shareholders would be critically important at this stage and at subsequent stages. And the KL2 education series, I know that when I had a K-12 award, I was allowed to attend them. And I suspect that other folks on campus who have career development awards would also be allowed to attend them, although I don't know that for 100% sure.
You are, so I'll just interject really quick, Heidi. Yeah, we invite anybody who's got a CDA, career development award, whether that's a K or a VA, independent or RKL2, we form cohorts with them. So as soon as I learn of someone who's gotten the award, we extend the invitation to become part of that seminar series.
Well, I am really grateful for everybody attending. Beverly, did you want to add something?
Thank you. I think that I know the comments are student facing on where this work can be applied in people's training, but I just want to offer that this is an opportunity for those who have maybe be working to revisit how they do business, not just in the research world, but also in administration, because these principles can be broadly applied and improve how we move institutions forward. And so as you all continue to develop this, I'm just hoping it becomes a little bit more inclusive of those who are maybe not in the trainee area, but those who maybe even staff who are working and have problems that they need to solve, who really need the training of the principles that you all presented here today.
That is great, Beverly. I should follow up with you later. That's really important.
I want to thank everybody for attending. Perhaps, John, would you be willing to put the link in the chat for the evaluation so that folks can complete our evaluation? If you're so willing, we really do like to see how this is going. It's a new seminar, as I mentioned. So if you can complete the survey in the chat and give us feedback about how it's going, we will take that and make it better. So thank you very much, and have a wonderful day and weekend. Thanks a lot.